Today, I will show the reverse stapedotomy, simple and safest stapedotomy surgery. To work with two hands, I always prefer the small endural incision, and retractor will be applied, and also one stitch will be applied to show the proper canal. So two hand will be active during surgery. Now small incision given, and I don't like any drops of blood. So cauterization also done. Now small incision with the blade, deep to bone incision. Look here, incision, and I will elevate with the circular knife with firm elevation. Look here, my right hand the circular knife, and left hand small tip sucker. Look how I will elevate. Elevation during stapedotomy is very, very important, because here it is this very thin, and there is a chance of tear of the flap. So elevation also important. Another important point here, I will elevate the flap with the chorda tympani nerve. So chorda tympani disturbance during surgery will be less. From where? Look here, small incision to create space. It will be more comfortable during. Sometimes small bone I am removing, some small soft tissue I am removing to create more space. Now technique of going the middle ear cavity, slight bit of difference from the tympanostomy surgery. Here I will first elevate with the chorda, not like tympanostomy. Tympanostomy, chorda tympani will be lateral position, will be the laterally, and flap will be elevation, keeping the chorda tympani. But here I will remove with the chorda. Look here, with the sickle knife or with the side knife, I will elevate. How I will elevate? So chorda tympani will be staying with the flap like tent. It's a totally unedited video. Look here. With chorda tympani, I am elevating the flap. So chorda tympani with attached with the flap, tympanometal flap. So during bone curettage and exposure, chorda tympani not create any disturbance. Now with the drill or curette, if you have no drill, or if you are not, sometimes be not interested to take the drill, I prefer the definitely drill, micro drill. Sometimes with the curette also possible. Look here, but away from the incus. Look, my curettage technique, exposure. This is the exposure. More exposure, more exposure. This is the quarter tympani nerve, the flap, and this is the incutiostapetal joint here. Now show more exposure required away from the incus. Otherwise, there is a chance of incutiostapetal joint dislocation. That is very, very important. Up to the pyramid. Up to pyramid, I will expose. So stapedial tendon attachment will be there. So during surgery, disturbance will be less during quarter tympani, during posterior crurotomy, disturbance will be less. Now, good focus and slight bit of foot plate exposed. So more exposure required. So more bone, I am curated as more bone. Now already slight bit of foot plate exposed, but still not I am happy, still slight bit of bone drilling required or curate is required. Always away from the incus, always, that is the main. That is the main. Now with exposure I am happy. Up to pyramid, now pyramid exposed, full stapedial tendon seen, lateral side facial nerve also seen, proper foot plate seen, posterior crura also seen. So if I zoom, then all will be clear. Look here. Now definitely we are happy after zooming. So if small bone speckle is there, just suck it or remove it. Anyway. Again check the movement. Totally fixed. Is a 10 magnification. Now I have the CO2 luminous laser, so I will do with the laser. Now I prefer the reverse stapedotomy. It's very simple because the reverse stapedotomy, why? When now just putting the gel foam to save the foot plate. Why I prefer the reverse or modify reverse? Because when I put the piston, still there will be the entry crura. So my slogan is the do everything before everything. First everything means piston placement. Last everything means superstructure removal. Now, with gel foam, foot plate protection. Now with the CO2 laser, 0.3 diameter CO2 laser, here I'll remove I'll vaporize the stapedotomy tendon first. Sometimes I do the first fenestration with the laser if good space is there. Here space is less, so I will vaporize the stapedotomy tendon first, then the posterior crura, then I will do fenestration and piston placement. So during piston placement, still anterior crura will be there. So it's very, very safe technique, because the still no foot plate movement will be there. So there is a chance of nerve loss, very, 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 very negligible. Because the no touch tech, now I am vaporizing the stapedotomy tendon, already stapedotomy tendon vaporized. Now my target is the posterior crura. 1 shot, 2 shots, 3 shots, 4 shots, and with 5 shots, I think stapedotomy posterior crura also will be vaporized. So slight bit of, if you see the posterior crura, some parts of the posterior crura, so that will be obstruction of the foot plate, so you vaporize the lower part also. Slight part, yes, vaporize. Otherwise, posterior part will be attached with different area with the promontory also sometimes. So just remove the posterior cross from the foot plate. Yeah, towards the promontory area. So no attachment with the upper part of the crura. So no connection of posterior crura with the head. So that is the main target. So posterior first, then stapedotomy tendon and posterior cross. So just gel foam is there over the foot plate. Why gel foam? To protect the foot plate here. Now remove the slight bit of posterior cross bone. So just vaporize. Okay. Removing the gel foam. Now clear foot plate. Now I am doing the laser aperture 0.8, because this aperture basically is the 0.7. If you put the perforator of 0.7, then basically with laser 0.8. So I always prefer the 0.8 diameter. Look here, the 0.8 diameter laser aperture. Now just zooming, more zooming. So 16 magnification. Look, this is the basically 0.8, means the perforator the 0.7. So I will put the piston of 0.5 diameter. So 0.2 millimeter will be more fenestration. So aram very comfortably piston will move. So no obstruction. If slight bit of obstruction, there will be slight bit of hearing loss will be there. So free movement of the piston is most important. Yeah. Now done the fenestration. Again, I will put the 0.6 diameter perforator to see the any obstruction is there or not. Sometimes if bony obstruction, so during piston placement, sometimes you will feel more disturbance. So I will check always with the perforator any obstruction is there or not. Look here, margin point. So margin point, if any obstruction, just touch. Now I am sure no obstruction point is there. So I will put the piston length after length. I have a paper already, established paper, 4.25 in case of female, 4.5 in case of. Still I measure every day, every case. Still I have seen more than 99% cases in case of female 4.25, in case of male 4. And same day discharge, I give that same day discharge because the measurement, if measurement and foot plate movement is very less, then vertigo is very less. Okay, this is the measurement. Now, if second touch the lower part of the incus, so this is the 4.25 plus 0.25 add, so 4.5 piston, 4.5 millimeter piston will be placed. Now how I put the piston, that is also very important. First, target to the fenestration. Look here, if I think this is possible, first target the fenestration. Look here, and then the over the incus. Yeah. Then with the crimp the piston. Look here. Normally prefer the grayish piston, the crimping. So here still, why it is the important modify reverse here? Still it is the fixation. No, incus still no movement. So piston placement is very easy because still anterior crura is there. Look here. So no movement of the incus. So it's very comfortable. Now I'll remove the anterior crura. That is the main magic of this operation. Last everything. So how I'll remove the anterior crura? Look here. Simply I am removing the anterior crura. Engaging sometimes difficult because that is the different type of instrument. So angulation is there. Anterior crurotomy knife. So angulation will be there. Look, this is anterior crurotomy done. Look, beautifully I have seen the anterior crura. So just remove the anterior crura. Slide, sometimes some part of the head will be there. Don't worry, that is also helpful for incus will be stable. No chance of piston slip. So just you may take the pick now and remove that part. Now removing the last everything. So here now, fantastic hearing check the with hearing. So patient will be very happy because the fantastic without any trauma, without any foot plate movement, without any injury, posterior also. So fantastic hearing, check the hearing, fantastic after the look, free movement, check, just place the, and quarter tympani also intact. Now place the graft, flap, so hearing check and patient is very happy. Okay. So this is the safest technique of stapedotomy surgery. Definitely you will appreciate, and if any question, please do question. I will definitely answer if possible. Thank you so much. Thank you for watching.